Welcome back to the deep dive. We're doing something a little different today. Think of it as your audio top-up, yeah? For that vital pediatric first aid knowledge you got with Paul from Paul Kinney Training about a year back.
Exactly. You did the 6-hour online, then that 6-hour practical.
That's the one. So this deep dive is really just about keeping those skills sharp, until you're back for the next practical in 2 years.
Yeah, it's not about relearning everything from scratch. You've got the foundation. This is more like a focused refresher.
A study guide almost.
Pretty much. We're using the PFA 12th edition handbook, Morley and Springer, as our guide today. Just hitting the key points.
Perfect. So it's about boosting your confidence, making sure you feel ready if, something happens.
That's the aim. Confidence and readiness.
Okay, let's dive straight in. Responsibilities of the pediatric first aider. What are those core aims we need to keep front of mind? Page 5 in the handbook, yeah.
Page 5, that's right. The big 3 are preserve life, prevent things from getting worse, and promote recovery.
Preserve, prevent, promote. Got it. The 3 Ps.
Exactly. Those are your guiding principles in any situation.
And beyond those principles, what about the sort of day-to-day or on-the-scene responsibilities?
Well, a big one is minimizing infection risk. Protecting yourself and the child. Basic hygiene, PPE.
Right, gloves and things.
Yeah, nitrile gloves, pocket masks for breaths, maybe eye protection, and then making sure your kit is actually ready to go, fully stocked.
Ah, good point. Easy to forget that.
It is. Then, when you arrive, that scene assessment, CLAP. Remember that?
CLAP. Control, look, assess, and protect, prioritize.
Spot on. Control the situation, look for any dangers, assess what's happened, then protect yourself and the casualty, and prioritize who needs help first if there's more than one.
And that prioritizing, how do we decide?
The handbook gives a good sequence. Breathing first, then major bleeding, then think bones and burns, and then other stuff after that.
Breathing, bleeding, bones, burns,
yeah.
Okay, makes sense. Handle the immediate life threats.
Exactly. And don't forget reporting the incident afterwards. That's important. And, crucially, looking after yourself, too, managing any stress from the incident.
Yeah, that post-incident stress is real.
Yeah.
You mentioned minimizing infection risk, the practical steps.
Good hand hygiene is number 1, obviously. Then using your PPE, properly nitrile gloves, those pediatric pocket masks we mentioned, eye protection if there's a splash risk, and disposing of waste correctly. Anything contaminated goes in a yellow clinical waste bag. Standard procedure, really.
Okay, so picture this. We arrive at an incident. How do we actually assess it safely? Page 8, is it?
Yeah, page 8. That CLAP scene survey is your first step. Make sure it's safe to approach.
Right.
Then communication. Especially with kids, they're going to be scared. So stay calm, be honest, but gentle.
Use their name.
Definitely, if you know it. Explain what you're doing, nice and simple. And if they've got a favorite toy or blanket, let them keep hold of it if you can. It can make a huge difference.
Little things matter. Okay, safety check, communication started. What about the actual initial checkup?
That's your primary survey, DRABCD. Or sometimes people call it Dr. ABCD.
DRABCD.
Right.
It's that quick, systematic check for anything immediately life-threatening.
Let's break it down. D, danger.
Yep. Check for danger to yourself, the casualty, anyone else around, before you even get close.
Okay. R is response. How do we check that differently for infants and children?
Good question. For an infant, talk to them, maybe gently tickle their foot or something. For an older child, talk clearly. Ask, are you all right? Maybe gently shake their shoulders.
And if they respond, even just a noise.
If they respond in any way, you move on to a secondary survey to check for other injuries and obviously get help if it's needed.
Okay. But if no response, straight to A, airway.
Straight to airway. Head tilt, chin lift.
Yeah.
But remember, for infants, keep the head neutral. Don't tilt it back too far. That can actually block their tiny airway.
Ah, right. Neutral for infants, gentle tilt for children. Then B is breathing. What are we actually doing there? Open the airway, then look, listen, and feel. Look for chest movement. Listen for breath sounds near their mouth. Feel for their breath on your cheek.
How long for?
No more than 10 seconds. And crucially, don't mistake those occasional gasps, agonal gasps, for normal breathing.
Right, they're not proper breaths.
No. If you're unsure at all if breathing is normal, assume it's not.
Okay. And if they're breathing normally but still unresponsive?
Then you do that secondary survey we mentioned, check them over, and get them into the recovery position if it's safe to keep that airway open.
Got it. C is circulation, which we'll get to with CPR, but the doctor part, calling for help, 999 or 112. When and how?
Get help coming ASAP. Use the LINE acronym when you call.
Fine.
Location, be precise. Incident, what's happened. Number of casualties. Extent of injuries. Clear and simple info.
Location, incident, number, extent. Good one.
And try not to leave the child alone if you can help it. Use speakerphone if you're on your own so you can stay with them.
Okay, so primary survey done. Let's say the child is unresponsive, but definitely breathing normally. Page 13 territory. What next?
That's when you do the secondary survey, the head-to-toe check. You're looking for any other injuries that weren't obvious initially.
Because young kids might not be able to tell you what hurts.
Exactly, so you need to be systematic.
Walk us through that head-to-toe check.
Okay, start gently with the head and face, look and feel for bumps, cuts, bleeding, anything unusual. Then the neck, feel carefully down the back, check for tenderness, loosen clothing.
Mm-hmm.
Then chest and shoulders, look for even breathing, feel for any tenderness or deformity, arms and havings, hands, check both arms, feel for injuries, look for medical bracelets.
Right.
Pelvis and abdomen, gently feel the tummy area for any rigidity or tenderness. Legs and feet, check both legs down to the toes. And finally, the spine, feel carefully along it if you can without moving them too much.
That's thorough. And after that check, if they're still unresponsive but breathing, it's recovery position time.
Yes, to keep that airway safe and let any fluids drain. It's slightly different for infants and children.
How so?
For an infant, you typically hold them face down along your forearm, supporting their head and neck with their head tilted slightly down. Keeps the airway clear, easy to monitor.
Okay, like cradling them downwards.
Kinda, yeah. For a child, you kneel beside them, arm nearest you out at a right angle, other arm across their chest, hand to cheek.
Hand to cheek, right.
Then bring their far knee up, foot flat. Use that knee and their hand on their cheek to gently roll them towards you onto their side.
Got it.
Then just adjust their top leg so the hip and knee are bent to keep them stable. Double check the airways open.
And keep watching them closely.
Constantly. Monitor their breathing. The handbook mentions potentially turning them to the other side after about 30 minutes if help is delayed and there's no spinal injury suspected, just to relieve pressure.
Okay. Let's switch gears to seizures. Page 17. Can look pretty scary. How do we spot one?
Yeah, they can be alarming. The book splits them into partial and generalized. Partial might just be brief changes, staring, odd feelings, tingling, maybe some twitching.
Mm-hmm.
Generalized are usually more dramatic convulsions, maybe shallow or blue-tinged breathing, confusion after, muscle stiffness, sometimes loss of consciousness or bladder control.
Right. So what's our immediate action?
Safety first. Clear the space around them, hard objects, sharp corners. Put something soft under their head if you can. Loosen tight neck clothing.
Don't restrain them.
Absolutely not. And never put anything in their mouth. Just let the seizure happen. Try and note the time it started and how long it lasts.
When do we call 999?
Call if it lasts more than, say, 5 minutes, or if they have another one straight after, or if it's their very first seizure. Always best to get checked out for a first seizure.
Okay. And after it stops?
Gently check their airway, clear any saliva, check breathing. Then recovery position. And be really sensitive. They might be confused or embarrassed, especially if they lost control of their bladder. Just reassure them calmly.
Good points. Now, after everything's calmed down, clearing up, page 19. Easy to overlook.
Very easy, but really important for infection control and being ready for next time. So safe disposal, yellow clinical waste bag for anything contaminated.
Right.
Thoroughly clean any spills of bodily fluids. Restock your first aid kit immediately with whatever you used. And of course, record and report the incident properly.
Okay. Now, the big one. Unresponsive and not breathing normally.
Yeah.
BLS and CPR, page 20. This is core stuff from the practical session.
Absolutely core. This is just a mental run through. First, recheck that breathing. Look, listen, feel, max 10 seconds. Remember those agonal gasps, not normal breathing, if in doubt.
Start CPR.
Start CPR. But first, those initial rescue breaths.
5 of them.
5 initial breaths. Open the airway. For an infant, mouth over their mouth and nose, gentle puff, watch the chest rise 5 times.
Okay.
For a child, pinch the nose shut, mouth to mouth, watch the chest rise 5 times. If you're alone, the guidance is do those 5 breaths, then about a minute of CPR before calling 999 if you can take the child with you.
Right. Then the compressions. How deep? How fast?
Okay. After the 5 breaths, it's 30 compressions, then 2 breaths. That cycle. Rate is 100 to 120 compressions per minute for both.
Fast. Like the Bee Gees song.
Exactly like Staying Alive, yeah. For an infant, use 2 fingers, center of the chest, lower half of the breastbone. Compress about 4 centimeters deep. That's roughly a third of their chest depth. 30 times.
2 fingers, 4 centimeters.
Got it. For a child, heel of one hand or two if they're bigger or you need more force. Same place, lower half of the breastbone. Compress about 5 centimeters, again, roughly a third of their chest depth, 30 times.
Heel of one hand, 5 centimeters. And keep going.
Keep going. 30 compressions, 2 breaths. Don't stop unless professional help takes over, you physically can't continue, or the child shows definite signs of life like normal breathing or coughing.
What if the breaths aren't going in? Chest isn't rising.
First, reopen the airway, check that head tilt chin lift again. Quickly look in the mouth for anything obvious you can see, but no blind finger sweeps. Make sure you haven't overextended an infant's neck. Try the breath again. Max 2 attempts at breaths before you go straight back to compressions. Compressions are vital.
Right. Don't delay compressions.
Yeah.
And calling 999 during CPR.
If someone else is there, get them to call immediately while you start or continue CPR. If you're alone and haven't called yet, do it after that first minute of CPR. Use speakerphone if you can.
And if an AED arrives, an automated external defibrillator.
Get someone to fetch it ASAP if one's available. Switch it on immediately. It talks to you, tells you exactly what to do.
Pads are different for kids.
Yeah, ideally use pediatric pads for children aged 1 to 8. They deliver a smaller shock. If you only have adult pads, you can use them. Just make sure they don't touch each other on the child's chest.
Where do they go?
The pads themselves, or the machine, will have diagrams showing placement, usually one on the upper right chest, one on the lower left side. Attach to them, let the machine analyze, and follow its instructions whether to shock or continue CPR.
Okay, let's talk choking. Foreign body airway obstruction. Page 24. Mild versus severe.
Crucial distinction. Mild obstruction. They can still cough, maybe wheeze or speak a bit. They're getting some air in. Severe obstruction. They can't cough effectively, can't breathe or speak, might clutch their throat. Skin color changes, they weaken fast.
Right. So for a choking infant, what's the sequence?
First, quick look in the mouth. Remove anything obvious if you can see it easily. No blind sweeps.
Okay.
Then support them face down along your forearm, head lower than their chest. Give up to 5 sharp back blows between the shoulder blades with the heel of your hand. Check after each blow.
5 back blows. If that doesn't work...
Turn them carefully face up, still head down. Give up to 5 chest thrusts. 2 fingers, center of chest, lower breastbone. Similar place to CPR compressions, but sharper, bit slower.
5 chest thrusts.
Repeat that cycle. 5 back blows, 5 chest thrusts. Keep going. Call 999 if it doesn't clear quickly. If they become unconscious, start CPR, starting with the 5 initial breaths.
And absolutely no abdominal thrusts on an infant.
Never. Only back blows and chest thrusts for infants.
Okay, what about a choking child?
First, if they're coughing effectively, encourage them. Keep watching closely.
Let them try to clear it themselves.
Yeah. But if the coughing is weak, ineffective, or stops, shout for help. Lean them forward and give up to 5 sharp back blows between the shoulder blades.
Same back blows. If they don't work.
Then, abdominal thrusts, the Heimlich maneuver. Stand or kneel behind them, arms around their waist. Make a fist. Place it thumb side in, just above their belly button, well below the ribs.
Right.
Grasp that fist with your other hand. Sharp inward and upward pull. Up to 5 times.
Yin and up.
Yep. Alternate. 5 back blows, 5 abdominal thrusts. Call 999 if it's not clearing. If they become unconscious, CPR again, starting with 5 breaths.
And always get them checked out after abdominal thrusts.
Yes, definitely seek medical attention afterwards, even if they seem okay, just in case of internal injury, or if they have trouble swallowing later.
Okay. Bleeding. External bleeding, page 29. Kids have less blood, right?
Much less. So any significant bleed is more serious for them. The handbook mentions the types. Capillary, like oozing from a graze, usually minor. Venous, darker red, flowing or gushing, more serious. Arterial, bright red, spurting, potentially life-threatening.
So how do we manage minor bleeding?
Gloves on first. Check for anything embedded. Clean the wounds, sterile wipe or running water. Sit them down if they feel woozy. Apply direct pressure if needed, then a sterile dressing or plaster. Keep an eye on it. Get advice if you're worried.
And for major bleeding?
Gloves on. Get them lying down quickly. Check for embedded objects. Deal with those specifically if present. Apply firm, direct pressure straight onto the wound with a sterile dressing or clean cloth.
What if it soaks through?
Apply a second dressing right on top of the first. Keep pressing. If that soaks through, the first seal probably wasn't good, so take both off. Apply a fresh one with firm pressure.
Ah, okay. Remove and restart if needed.
Yes. Treat for shock, keep them warm, legs raised slightly if possible. No food or drink. Call 999 immediately. Keep monitoring.
And if there's an embedded object in the wound? Page 30.
Key thing. Do not remove it.
Right.
Try to keep the child calm, distract them, get them sitting or lying down, apply pressure around the object, not directly on it. Build padding around it to keep it stable, then put a larger dressing over the top. Secure it well. Call 999, monitor, treat for shock.
Okay. Which brings us nicely to shock itself. Page 33. How do we recognize it?
Look for pale, cool, clammy skin. Breathing might be rapid and shallow. They might seem weak, maybe restless or anxious. Pulse could be weak and fast, maybe less wee than usual.
And the treatment?
Call 999 straight away. Treat the cause if you can, like stopping major bleeding. Lie them down, raise their legs slightly if injuries allow. Loosen tight clothes, keep them warm, no food or drink. Monitor airway and breathing constantly.
The book mentions hypovolemic shock specifically.
Yeah, that's shock caused by losing a lot of fluid volume. Could be blood loss or severe vomiting, diarrhea, burns, heat stroke, anything causing major fluid loss. Very common cause of shock in children.
Got it. Bites and stings next, page 34. Mostly minor, but allergies are a risk.
Exactly. Mosquitoes, wasps, bees, ticks. Usually just local irritation. But watch for allergies or infection. Gloves on. Reassure. If it's a bee sting, try to scrape the stinger out sideways, don't squeeze it.
Don't squeeze.
Yeah. Watch their breathing, call 999 immediately if you suspect anaphylaxis, severe allergic reaction. Get medical advice anyway if you're worried.
Animal bites. Dogs, cats.
Main risk is infection. Make sure it's safe first. Reassure, gloves on. Control bleeding. Clean dressing. Always needs proper medical attention for cleaning, maybe antibiotics, tetanus check.
False widow spiders, they get talked about a lot.
They do. Bites can be painful, cause swelling, but serious reactions are very rare in the UK. No confirmed deaths. If bitten, wash it well, monitor. Seek help if it looks infected or symptoms worsen. Try to identify the spider if you can do it safely.
Okay. Minor injuries, page 36. Cuts, grazes, bruises.
Pretty standard stuff. Minor cuts, grazes, gloves, check for dirt, clean well, maybe a plaster or dressing, bruises. Remember rice? Rest the part. Ice wrapped, 20 minutes on, then off. Compression, gentle bandage, and suitable. Elevation, raise the limb if possible. Helps reduce swelling.
Good reminder. Splinters.
If sticking out. Gloves, clean area, use sterile tweezers, pull it out the way it went in. Clean again, watch for infection. If it's fully under the skin or big or under a nail, maybe try a plaster overnight to draw it, but probably best to get medical help to remove it properly.
Nosebleeds, page 38. We kind of covered this, but quick recap.
Yep. Sit child forward, infant position safely. Pinch the soft part of the nose firmly. Breathe through the mouth. Hold for 10 minutes. Release gently. Repeat if needed. If still bleeding after 30 minutes total, seek medical help. No picking or blowing nose afterwards for a while.
Okay. Bones, joints, muscles. Page 39, fractures first.
Breaks or cracks.
Yeah.
Can be closed, skin intact, open, bone showing infection risk, complicated damaging nerves vessels, and green stick common in kids where the bone bends and cracks but doesn't fully break.
How do we spot a fracture?
Pain, tenderness, swelling, bruising, maybe deformity, inability to move it, sometimes that horrible grating sound, crepitus, open wound if it's an open fracture, shock is possible.
Treatment.
Gloves. Control bleeding if open. Immobilize the limb how you find it. Don't try to straighten it. Support it. Treat for shock. Call 999.
Dislocations. That's the joint coming out of place.
Exactly. Bones separated at the joint. Often looks deformed. Very painful. Loss of movement, swelling. Common in kids' shoulders from being swung.
Treatment, same as fractures.
Pretty much. Gloves. Immobilize as found. Treat shock. Call 999. Don't try to pop it back in yourself.
Definitely not. The book mentions slings. Elevated and support.
Yeah, elevated sling lifts the hand higher, good for collarbone, hand, forearm injuries, especially with bleeding. Support sling just takes the weight for wrist, forearm, upper arm injuries. The handbook shows how to tie them with a triangular bandage.
Sprains and strains, less likely in younger kids.
Yeah, their ligaments, sprains, are often stronger than their bones, more common in older, active kids. Sprain is ligament damage, strain is muscle tendon damage, both treated initially with rice.
Right, rice again. Okay, head, neck, and back injuries. Page 44. Always serious.
Always potentially very serious. Head injuries range from concussion, brief LOC, dizziness, headache, to cerebral compression, pressure buildup, drowsiness, unequal pupils, needs urgent help. To skull fracture, wound, deformity, maybe fluid from Erno's CSF.
How do we manage a head injury?
If conscious, call 999, keep them comfortable, head and shoulders raised slightly. Control bleeding CSF leakage gently, monitor closely. If unconscious, call 999, keep them still, support head neck, keep warm, check breathing. If not breathing, BLS. If breathing, recovery position if you can do it while keeping the spine aligned, but be super careful, especially if skull fracture suspected. Don't ask questions that make them nod or shake their head.
And neck or back injuries. Risk of paralysis.
Huge risk. Look for pain, odd position, inability to move limbs, tingling, loss of sensation, or bowel bladder control. Conscious. Call 999, keep them completely still, support head and neck manually in the position found, keep warm, unconscious. 999, check breathing, BLS if needed, maintaining alignment as much as possible. If breathing, don't move unless essential for safety or airway. Keep head, neck, spine aligned if you have to move them. Stabilizing the head and neck is priority.
Okay. Eyes, ears, nose issues, page 47. Foreign objects.
Eye. Infant, get medical help straight away. Child, don't let them rub. Try to see it. Blinking or tears might flush it. Gentle eye wash, maybe. If you can't get it out, hover gently, seek help. If embedded, definitely don't remove. Cover gently. Immediate help.
Ear object.
Don't try to remove it. Risk of pushing it in or damaging the eardrum. Cover gently. Seek medical help.
Nose object.
Try getting the child to blow their nose gently while blocking the other nostril. If infant or that doesn't work, seek help. Don't poke around.
Okay. Acute medical conditions, page 48. Big section. Sickle cell first.
Hereditary condition. Look for pain episodes, especially hands, feet, and young kids, drowsiness, fever, breathing issues. Follow their care plan if they have one. Call 999 for severe pain, breathing problems, or if no plan known.
Diabetic emergency. Hypo and hyper.
Hypoglycemia, low sugar, comes on fast. Shaky, sweaty, confused, hungry, headache, maybe unconscious. Give sugary drink food if conscious. Call 999 if unresponsive but not improving. Hyperglycemia, high sugar is slower. Thirsty, weeing lots, fruity breath, drowsy, needs medical assessment.
Asthma attack.
Wheezing, coughing, tight chest, difficulty breathing. Let them sit up, use the reliever inhaler, usually blue with a spacer. Follow their plan, reassure. Call 999 if severe, prolonged, or first attack.
Meningitis and septicemia. Very serious.
Extremely. Fever, cold hands, feet, vomiting, severe headache or stiff neck, dislike of bright lights, drowsiness, confusion, maybe seizures. Infants might refuse feeds, have a high-pitched cry, bulging soft spot, and that rash.
The non-fading rash.
Oh, God.
The glass test.
Yes. If our rash doesn't fade when you press a glass against it, that's a major red flag for septicemia. Call 999 immediately. But don't wait for a rash. If you suspect meningitis septicemia, call 999 based on the other symptoms too. Time is critical.
Allergic reactions, including anaphylaxis.
Mild reactions might be itchy eyes, rash. Note the trigger. See a doctor later. Severe is anaphylaxis. Rapid onset affects breathing, swelling throat, tongue, circulation, dizziness, skin, widespread rash swelling. Call 999 immediately. Help them use their adrenaline auto-injector, EpiPen Jext if they have one. Lie them flat, legs raised if breathing okay. Maybe second dose after 5-15 months if no improvement. Be ready for BLS.
Febrile convulsions. Fits caused by fever.
Yeah, happens in young kids with a rapid temperature spike. They fit, stiffen, then jerk. Protect from injury. Cushion head, clear space. Time it. Once it stops, check airway breathing, recovery position. Try to cool them gently. Remove layers. Call 999, especially if first timer lasts 5 minutes. Reassure it afterwards.
Okay. Extreme heat and cold, page 54. Hypothermia first.
Dangerously cold. Pale, cold skin, shivering stops eventually. Lethargy, slow breathing pulse, confusion, unresponsive. Get them somewhere warm gently. Remove wet clothes, use dry blankets, warm drinks if conscious. Seek help. Warm them slowly, no direct heat.
Frostbite. Freezing tissues.
Fingers, toes usually. Pins and needles, then skin hardens, painful then numb, color changes. Get them out of cold. Warm gently with body heat. Cover up. Immediate medical help.
Heat exhaustion. Overheating, sweating lots.
Hot, flushed, sweaty skin. Headache, nausea, tired, rapid pulse. Move to cool place, give water, remove excess clothes, monitor, seek help if not improving.
And heat stroke. Medical emergency.
Yes. Body's cooling fails. Very high temp, often hot, dry skin, headache, dizzy, vomiting, confusion, rapid pulse breathing, maybe unconscious. Call 999, move to cool place, cool them actively. Wet cloth, spray water, give water if conscious, be ready for BLS. Prevention is key here. Shade, fluids, avoid hottest sun.
Electric shock, page 58. High versus low voltage.
High voltage, power lines. Extremely dangerous. Stay well back. 18 meters minimum. Call 999 in power company. Don't approach until declared safe. Low voltage, household. Safety first. Turn off power at source. Microplug. Then, check response. If unresponsive, not breathing, BLS and 999. Check for burns.
Burns and scalds. Page 60. Different types and depths.
Causes: heat, cold, chemicals, electricity, radiation. Scalds are wet heat. Depths: superficial, red, painful, like sunburn. Partial thickness: blisters, raw, very painful. Full thickness, deep, charred white leathery, may be less painful due to nerve damage.
Management depends on depth.
Yes, but all burns need cooling. Cool running water for at least 20 minutes. That's vital.
20 minutes minimum.
Superficial, cool, 20 mins, remove tight stuff unless stuck, cover loosely, discard first bit. Seek help if large area, 5% or airway affected.
Axillary thickness.
Cool 20 mins, remove loose stuff, flush around stuck stuff, don't burst blisters, cover loosely, sterile, non-fluffy dressing or clean film. Seek help if 1% body area or face, hands, feet, genitals joints or airway. Treat for shock if 9%.
Full thickness.
Cool 20 mins, remove loose stuff, flush around stuck, don't burst blisters, cover loosely. Immediate 999, treat for shock.
Chemical burns to eye.
Flush with loads of running water for at least 20 mins, tilting head so water runs away from other eye. Sterile pad, immediate hospital trip.
Poisoning, page 65. Swallowed, inhaled, absorbed.
Exactly. Look for clues. Stomach pain, odd breathing, heart rate, smells, burns around mouth, vomiting, drowsiness. Call 999 immediately. Make sure scene is safe for you. Try to identify the poison. Move child away from source if safe. Be ready for BLS. Use face shield if inhaled poison.
Don't make them sick.
Not unless told to by 111 or 999. Get as much info for paramedics as possible. What, when, how much, symptoms, child's details, keep containers.
Anaphylaxis, again, briefly, page 66, just to reinforce.
Severe, rapid allergic reactions, swollen mouth, throat, face, difficulty breathing, skin changes, maybe collapse. Call 999. Use adrenaline auto-injector immediately if available. Lie flat, legs raised if conscious breathing. Monitor. BLS if needed. Needs hospital follow-up always.
Finally, records. Page 68. Why is keeping records so important?
It's crucial. Accident book or similar. Need date, time, location, child's details, what happened, injury illness details, first aid given, what happened next, parents called, hospital, etc. Your details.
What's the point of all that paperwork?
Help spot trends, manage risks, informs future assessments, might be needed for investigations, and sometimes you legally have to report serious incidents, RIDDOR, HSE, Ofsted, child protection agencies, depending on the setting.
And keep it confidential.
Absolutely. GDPR applies. Keep records secure, only accessible to those who need to know.
Well, that was quite a run-through, a rapid refresher, but hopefully really useful, covering those key points from your training with Paul and the PFA handbook.
Yeah, hope it's jogged your memory on the crucial bits and maybe boosted that confidence a little.
Definitely feel more prepped.
Good. We really do encourage you, though. Take some time yourself. Flick back through that handbook, especially any bits you felt rusty on, and mentally walk through those practical skills you learned.
Yeah, that hands-on practice is key, isn't it?
It really is. Knowing it is one thing, feeling confident doing it is another.
So a final thought for everyone listening. We know the theory, we've done the practice.
Yeah.
But how do we make sure we cultivate that calm, decisive mindset to actually use these skills effectively when the pressure's on in those real-life moments with children? Something to think about.
Definitely worth reflecting on. Until next time.
Until our next deep dive.